nurse educators and content developers for the Princeton Review. I'm a certified nurse educator, and I currently teach in a pre-licensure BSN program in Central Florida. My nursing background includes maternal child nursing and emergency nursing. Before we get started, I want to say that there are lots of different medications used in maternal child nursing. This video is strictly going to focus on the medications that you are most likely to see in questions on the NCLEX. For more in-depth content on OB meds or other maternal newborn content, please check out the Princeton Review's full NCLEX review program. Let's get started. The first medication that we're going to talk about is oxytocin. Oxytocin is a synthetic hormone that causes uterine contractions. It can be used to induce labor or to augment labor when the existing maternal contractions are not effective. It can also be given after delivery to reduce postpartum bleeding. On this slide, we're going to discuss oxytocin for the induction and the augmentation of labor. For assessment, when you give oxytocin for induction or augmentation of labor, the nurse should continually assess fetal well-being and contraction patterns. One of the risks of oxytocin is uterine hyperstimulation. This means that the uterus contracts too frequently or for too long. Hyperstimulation places too much stress on the uterus and can negatively affect fetal oxygenation. So it's important to assess the fetal heart rate, contraction frequency, and contraction duration. For the administration, oxytocin is given via IV so that it can quickly be discontinued if any complications occur. It should always be administered with a pump, and it should be attached to the port closest to the patient to prevent an accidental bolus. Oxytocin is titrated by the nurse to achieve adequate contraction patterns, so dosing will vary. For evaluation, the nurse will determine if oxytocin is effective by evaluating the client's contraction pattern and eventually cervical dilation. The use of oxytocin should cause an increase in the frequency, duration, and strength of contractions. Adequate contractions will ultimately cause cervical change. Next is magnesium sulfate. Magnesium sulfate is a central nervous system depressant used to treat preeclampsia and eclampsia. It can also be given at a lower dose to clients at risk of preterm delivery for fetal neurological protection. This slide will focus on the administration for preeclampsia and eclampsia. For the assessment, magnesium sulfate is considered a high-risk medication because it can cause serious cardiac and respiratory complications if toxicity occurs. The nurse will do specific assessments to monitor the client for signs or symptoms of magnesium toxicity. First, the nurse will frequently assess the client's blood pressure, heart rate, respiratory rate, and oxygen saturation, looking for any signs of respiratory depression or cardiac abnormalities. The nurse will also monitor urine output closely. Magnesium sulfate is excreted through the urine, so a low urine output leaves the client at risk for developing magnesium toxicity. Urine output should be at least 30 milliliters per hour. Another important assessment is deep tendon reflexes. Because magnesium sulfate is a CNS depressant, excess serum magnesium will cause a decrease in deep tendon reflexes. For administration, magnesium sulfate is administered in two separate steps: a concentrated loading dose, then that's followed by a maintenance dose. Magnesium sulfate should always be administered with an IV pump, and it should be attached to the port closest to the patient. Calcium gluconate, which is the magnesium antidote, should always be readily available. For evaluation and follow-up, the client receiving magnesium sulfate for preeclampsia or eclampsia should experience improvement or prevention of neurological irritability. The nurse should monitor for visual changes, headache, or changes in deep tendon reflexes, or any other signs of neurological irritability. Last, expect to draw blood on this patient frequently. A serum magnesium level will be monitored at regular intervals to ensure that therapeutic levels are maintained. Now let's talk about betamethasone. Betamethasone is a corticosteroid injection that is given to a pregnant woman to help increase fetal lung maturity. It is only administered to mothers who may experience a preterm delivery to help reduce the risk of newborn respiratory distress syndrome. For the assessment, Any signs and symptoms that indicate that a preterm delivery may occur should be reported to the provider. Also, determining the gestational age of the client is important because this medication is only indicated prior to 34 weeks. Administration considerations. Betamethasone is given intramuscularly. Typically, the client will receive the injection and then get a second injection approximately 24 hours later. For follow-up and evaluation, the nurse should evaluate maternal vital signs, paying close attention to heart rate. Tachycardia is an adverse effect of betamethasone. Close assessment of the injection site for irritation or signs of infection should also occur. Once delivery has happened, assess the newborn for signs or symptoms of respiratory distress. The next medication, or actually medications, that we will talk about are opioid analgesics. Common examples of these are butorphanol, nalbuphine, and fentanyl. Instead of just talking about one particular medication, let's cover the entire group. Opioid analgesics are given to reduce pain in labor and can be administered intravenously or intramuscularly. These medications are narcotics, so careful assessment is needed prior to administration. Pain level, maternal vital signs, and fetal heart rate specifically should be assessed before giving any opioid analgesic. If there is concern about the fetal heart rate, such as decreased variability or repetitive decelerations, narcotics may cause worsening of these concerns. Labor progress should also be assessed prior to administration to determine cervical dilation. Narcotics should be avoided if delivery is expected in the very near future. Opioid analgesics do cross the placenta and may affect the respiratory drive of a newborn if given immediately before delivery. For this reason, naloxone, a narcotic antagonist, should be easily accessible in the event that a newborn has significant respiratory distress after delivery. Because the purpose of this medication is to alleviate maternal pain, the client's level of pain should be reassessed 30 minutes to 1 hour after administration. Maternal vital signs should be monitored to ensure that hypotension, bradycardia, or respiratory depression does not occur. The nurse will also evaluate fetal well-being for any signs of fetal distress. The last item to discuss is RhoGAM. RhoGAM is an injection of Rh antibodies given to mothers who are Rh negative. Mothers who are Rh negative may become sensitized to the Rh factor, and if they are carrying a fetus who is Rh positive, complications may occur. Administering the Rh immunoglobulin to the mother reduces the number of antibodies that she produces and prevents sensitization. For the assessment, blood typing and antibody screen of the mother will be performed. For Rh negative mothers, an antibody titer will be completed to determine if Rh sensitization has occurred. Blood type and antibody screen of the baby will also occur after delivery. For administration, RhoGAM is given to Rh negative mothers at 28 weeks gestation. It is also given 72 hours after delivery if the baby was Rh positive. For follow-up, the RhoGAM must be administered with every pregnancy because the effects of the injection last 1 to 2 months. That concludes the content for the top 5 OB medications that you need to know for the NCLEX. I hope you found this video useful for your studying. If you're interested in more in-depth information, the Princeton Review does offer a full NCLEX review program. Thanks for watching.